just go do something. Don't talk about doing something. Just go do it. Like, what's the worst that can happen? Doing something. Doesn't work. Ooh, but it might work. But it's so much better than just talking about doing something, right? And whether it's old Teddy Roosevelt talking about the man in the arena and kind of like it's like the person that just kind of goes and does something rather than just criticize or talk about it, or you name it. It's like just go try.
Step into the world of success with your brand amplified, the ultimate podcast designed to unravel the intricacies of thriving businesses. I'm your host, Annika Jackson, and I'm on a mission to uncover the stories, strategies, and secrets that have propelled entrepreneurs and business leaders to success. I have always looked at healthcare as something that is a right, not a privilege. And I've seen many different sides of it, from being Thai and Lao and having dual citizenship, with working with organizations in Ghana, seeing how healthcare is approached in different countries on top of all of the issues that we have here in the United States. So I'm really excited to dive in with Mark Newman today. You are founder and CEO at Nomi Health. So thank you, first and foremost, for what you're trying to do and what you are doing to put some good energy into this area that frustrates so many people.
Yeah, it is literally the most broken market in the entire world. It's U.S. healthcare on a standalone basis is the third largest country if it was its own, like from a GDP standpoint, if it was its own thing, right? It'd go Canada, or it'd go US, China, and then American healthcare, because it's like $5.5 trillion before Germany. And it's a walking disaster. So thanks for having me. Excited to jump in.
Yeah. Let's talk about first how you went from international business and master's in finance into healthcare as your passion and your skill set.
Yeah, I've been fortunate. When I was in college and graduating with that degree, 20 years ago, my co-founder and I started a company called HireView, which was all around video-based assessment, machine learning, and AI. And when you're in college and 20 years old, you think I might do this for a couple of years. 15 years later, we're selling the business, and and to this day, it still has a magnitudinal impact on how people get jobs across the world. And that was just so fun. That was the greatest possible way I could spend my 20s and early 30s. I never thought, when you have the opportunity to do something that like you love so much, and and it's not a job at that point, it's your work, it's your craft. And I never thought that there'd be something else more, right? Kind of this, that was my thing. And then life happens in funny, peculiar ways. So I'm at the birth of my son, 3 kids, and this lovely person comes into our hospital room, says, "Congratulations on your new baby." And I'm like, "Thank you. Who are you?" She's like, "I'm from finance. I'm here to talk to you about your bill before you leave." And I was like, "Oh, okay." And I was ready for this moment, because think about it. Like, I was building HireView. We helped companies hire. So all I did was hang out with HR people. All I did was, I knew about some element of benefits. We were in tech. We had great healthcare. We had this, we had that. And I said, "Fantastic." I said, what's the bill?" She said, "Oh, we've worked with your insurance company. We have this flat gold price. It's $4,500. And I'm like, "Great, fantastic. Here you go." And I give her my payment card. She's like, "What do you want me to do with this?" And I sat there and I was like, "Well, how about I pay the bill?" And she goes, "Well, you can do a payment plan or this." And I said, "Well, what if I pay the whole thing?" She's like, "If you do that, I'll take 30% off right now." And I sat there and I was just angry. I had money and I showed up and I got a lower price. It made no sense, right? I'd just gone through a massive benefits cost increase year over year. And when you're talking about international healthcare, my dad is English. I'm a British citizen. I was born in Canada. I'm a Canadian citizen, and I'm a U.S. citizen.
Oh my God.
So in that regard, so I've seen all flavors of this, and I was like, I was passionately like wronged by this idea that I had money and I got a lower price. So lo and behold, I decided then and there I was going to be building another company. It turns out that the same people that buy all the software to how they hire teams are also the same people that buy all the benefits on how they deliver care to their people. So I guess HR is my tribe, as it were, right? Like all I do is hang out with HR my entire career. And for the last 6 years, Nomi has been building Nomi Health. And Nomi is totally focused on working for self-insured employers, which are any employer about 200 employees and above, to figure out how to rebuild their healthcare at, ideally half the cost. And we're on our way. We're about 25-30% there.
What a story. The fact that she was willing to take off that much money immediately because you made a payment in full. That's
that wasn't a healthcare problem. That's the irony here, right? It wasn't a clinical thing. It wasn't an innovation that the FDA approved or whatever. It was a good old fashioned business problem because today a provider in America, doesn't matter if it's a hospital or a doctor, I could say, "Hi, nice to meet you, Miss Jackson. Thank you for coming today. Good to see you." And you walk out the door. They have no idea when they're going to get paid, who they're going to get paid by, how much they're going to get paid, how hard it's going to take to get paid. Do they have to bill you? Do they have to bill the insurance company? Who do they have to collect from? They have to wait for the insurance company to tell them first if they're supposed to collect from you. How long do they have to chase after? And all that weird note taking they were doing during the entire visit, was that enough to self justify the work that they did to get paid, I don't know, $150 for seeing you today and going and do that. And, I think most doctors are filled with regret because they're like, how much did I spend on my education to justify getting paid $150 for a primary care visit? But it's a broken market. There's very little basis of actual contract law, if you think about it, in US healthcare, because you can deliver service and not get paid for it, even though there's a contract that exists between you and a provider or you and an insurance company or whatever. And so it's completely broken. And as a result of that, the only thing you can do is price in the risk of non-payment. So if someone guarantees the payment to you, it turns out you can offer them the real price of healthcare, which is the price that you think you're going to get after fighting and begging for 2 to 9 months to figure out how to get it.
Wow. Yeah. And on the other side, we see issues with people getting the right amount of care because the healthcare system is complex. And if you have a PPO or an HMO or some other kind of insurance, you don't know, you might get that thinking it's the best one, and then maybe you don't have access to doctors.
For sure.
Or doctors that are close to you, or doctors that are taking new patients. Or because you made one offhand comment, they're not going to let you have something that's under routine care, and they're going to charge you extra for it. So it seems to me that you're trying to take out some of the complexity and add some transparency into the system. So I'd love to hear a little bit about what that looked like, what you first envisioned, and then how you took that vision into these organizations.
You nailed the crux of it. It wasn't coming out with a new tool to address the complexity. Does it make sense? Like, we weren't trying to build Nomi to say, hey, providers, here's how you collect more and extract more from your patients, or hey, here's how you do this, or here's how you do that. It's actually trying to build a parallel system that simplifies the act of buying and paying for healthcare that an employer is delivering to the people that work for them. So we do a couple of things. First, we want to ground all spend in fact and truth. So we are the largest data platform for self-insured plans for these employers. What do they spend their money on? Where do they spend it? What is going on? What are the gaps in care? What are the needs? What are this? What are that? Because to this day, if you talk to 10 CEOs and you said, how much do you spend on healthcare? They would look at you and everyone complains about it. But I bet you maybe half of them, maybe 7 out of 10 even know. And then you go, right. Say they're right. Say they know, oh, it's, $3.7 million that we have budgeted this year. Okay, great. On what? Maybe half of them know medical versus pharmacy. Does that make sense? And it's a rough estimate, right? And we're like, no, on what? On what facilities, on what places, on what things, on what health conditions, like what are kind of happening? And like maybe 1 out of 10 know that. And we think that that's part of like how we all get hoodwinked as Americans, right? Because there's like this information asymmetry from the insurance companies to the brokers, to the consultants, to the HR people, up to the CFOs and CEOs of these organizations. There's information asymmetry, whether it's hiding behind HIPAA and privacy, whether it's saying, oh, it's too complex, you wouldn't understand, whether it's this, whether it's that, whether it's not digital, right? And so we want to solve all that. So we have roughly almost 2,000 employers with about 17 million lives kind of on our platform, what they spend their money on, where they spend it, how they would do it. Open up the black box.
Yeah.
Then we've built our own direct-to-provider payment system because ultimately those employers are happy to replicate the experience that I had of solving a business problem for a provider to access a lower price or the best commercially available price of that service. We don't have to get hung up on constructs of weird plan designs like you talk to, or deductibles or copays or this or that, when it's like, all right, if healthcare costs for a family was going to be $10,000, and if we pay it directly, it's $6,000. Do we really care about the deductibles or copays that people have, or whatever, right? And so we built that, and so we pay providers nationally, both for our own access as well as supporting other TPAs and their payments. And then the third bucket is then mobilizing both data and payments to buy direct access to medical and pharmacy services. Okay, so whether it's getting drug at the lowest net costs or like paying a provider directly, for that, and that's something you have to go build hospital by hospital, doctor's office by doctor's office to get them on board and kind of get them into it, because we don't want this to be an experience where you show up, you give them the card, and they're like, I have no idea what to do with this, right? We want to establish a relationship, kind of go after it this way. And that's just simplifying things. You didn't hear me say, oh, we want to get into the intervening part of when it goes to the clearinghouse and to intercept 835s, 837s to go do this thing. It's like Mystery Science 3 or 3000 sometimes, talking about an interocitor. It's absurd.
Yeah.
And so we just want to build a very simple, streamlined, transparent, data-driven approach to how employers can buy healthcare for that work for them. They can figure out cost sharing later. They can make that part of payroll or whatever. And our success is when we work, or like our target customer or organizations where a massive part of their organization makes less than $100,000 a year. Because effectively in America now, they're healthcare poor, right? Like they're one bad accident away from having a $5,000 deductible that they can't afford, and, kind of have to go after it and do it this way. And we get to show up, and when we're kind of fully deployed inside of an organization, there's no copays, no deductibles for those people that work there and their families. Everything's data driven, everything's transparent, and people have lower healthcare costs. And like those are some of the things we should be doing as America, we believe, not just putting up with how it works.
Yeah, it seems like healthcare is obviously the biggest broken system, but there's so many systems that could also replicate this model and be better for it for all of us.
Well, the irony is so many of these things, we aren't coming up with like some crazy brand new innovation that didn't exist before. We're like, hey, provider, if you were a restaurant, somebody would come, they would order from a menu of services, about 50 to 80 different SKUs with all sorts of customizations and configurations, which is no different than a doctor's office, right? And, they would do that. They would get work. You would present them a bill. You would get their credit card generally, maybe cash, who knows, but get a credit card generally. When they swipe that credit card, it goes through something on the order of 400 different systems in about 10 seconds. Around, is this appropriate? Were you there? Were you traveling there? Does this seem like something you would buy or what you would go do? Is this a good vendor? Is this all those kind of various things? The answer comes back and says yes. And then you get presented a bill that you can add a gratuity on that they can type in, then they get their money, and it's a couple days later.
Yeah.
So, like, we're not coming up with rocket science. Healthcare, to state of the art on healthcare today, is about 60% of payments are through paper check. Okay. They're disconnected from the forms and documents that come with them. You get a bunch of stuff sent to you in the mail. So then what do you have to do? Invest in this new innovation called fax management and OCR technology to scan the giant piles of crap you get sent to your office, to then go to a lockbox, to then go to a billing company to try to reconcile it back to get some report, 30 or 60 days later. We operate as if it's the 1970s.
Yeah.
And we're just trying to apply everything else that we expect in our personal lives. Like, you book a flight to Miami, it comes up with a rental car and hotel, show tickets, weather opportunities, reservations, you name it. In healthcare, if you book a flight to Miami, you'd end up in Iceland. You get a bill for it 6 months later. You wouldn't even have a flight. You'd have a rental car. And we're just trying to simplify that and apply best practices in other places to just simplifying buying and paying for all.
Yeah. Well, and this also goes right along with data privacy, which is obviously state by state in the United States. And some states also have AI regulations, some don't. But one thing I've heard a lot from people who, actually in Utah, people who are on these committees and trying to help the state formulate what they're going to do, is that some of these organizations are not digitized at all. And so you have to get them digitized, but then, to even get to the next step of making sure that you're holding the information private. Obviously, you have a long history because with your first company, you were already using AI, whether we called it that or not. You're using machine algorithms, machine learning to create this database and configuration. So you already had a lot of expertise in that. How did you build that expertise in? Like, how did you know that that's what you needed to do to make sure that your company was at the forefront of helping people find the right people and creating new ways for people to speak to prospective employers and go
For
through that
sure.
process.
Yeah, I mean, part of it is life's tuition. There's no, it's like and you just kind of keep iterating, growing, and investing in it. And I had a terrific technical co-founder at HireVue, guy named Lauren Larson, and we've both gone on to build healthcare companies together. He's on our board here at Nomi and helped co-found with his. We built Videra Health together, which is the same thing around video, machine learning, and AI about people taking really kind of scary medications or things with subjective side
Mm.
effects. For Nomi, I have two other co-founders, Josh Walker, who's 25 years of U.S. healthcare experience, and then Paul Hartman, who is the chief digital officer of Goldman Sachs, where he built Apple Card and Marcus there, and we knew each other from Capital One and Barclays Card. So we wanted to combine together employer and enterprise software expertise with banking and fintech with healthcare, right? Kind of the
Right.
three flavors together, because companies know how to deal with private data. Doesn't make sense. Like just because it's a SaaS or cloud-based platform of healthcare data does not mean everyone in an employer has access to that data. Or doesn't make sense. Like just like the legal counsel, the legal group has access to certain data that the rest of the organization doesn't have, and just like finance has access to certain data that it's like there is information asymmetry inside of organizations that's protected, confidential, and private on a regular basis. We like to think that we work with employers and companies that hire adults, right? And so as a result, you have the right provision safeguards to be able to kind of go and do that. And then once you expect that, of course, records should be digitized, then you talk about what you do with them, right? And you nailed it. Like sometimes you're in Utah and you're like, wait, you are the supposedly one of the nation's highest rated health information exchanges, but because University of Utah doesn't like Intermountain for something, or HCA pissed off somebody over here, or Intermountain upset so and so, or whatever, like in our like little fishbowl of a market, like you can't pass records. Right? My dad goes to two different health systems here, and he has a very severe blood disorder, and he has to go get blood tests at both systems weekly because they don't talk to each other.
Oh my gosh.
And
Yeah.
they won't send results, and they don't trust each other. And you're just like, come on, children. We can do hard things, right? We
Right.
expect our kids and our families to do hard things. We can do hard things here too. But what it also comes down to is money. Inside of healthcare, there is a capital and monetary advantage to information asymmetry. Meaning, like, and unfortunately, because of that, and there's very little expectation, like a fully digitized system with real-time payments and real-time reconciliation of dollars would mean like no one can hide. If how we expect credit card spending to work is how healthcare spending and payments would work, which is actually a smaller amount of money than even American Express or Visa. You know what I mean? Kind of gets moved inside of it. If we expected that in healthcare and that's how it was delivered, we would very quickly know that a dollar is not a dollar to anybody. Meaning a dollar in like a bill that you and I get is $1.20 to $1.30 to an employer, and is like 70 cents to a provider, and is 50 cents over here, and the government thinks it's this, and the broker consultant thinks it's that, and and it would just be this ace, and everyone makes money off of the asymmetry. And so I think one of the best administrative opportunities that, and they could say, oh, it might take 10 years, it might take 5 years, or whatever it is, by 2030, there will be no checks in healthcare, like no paper checks. There will be no paper records, and there will be a national industry ledger that shows, a claim getting paid.
Yep.
And if claims don't get paid, they will be flagged for review about why.
Well, I think as we move towards, you know, further into Web 3 and Web 4, most people are living in Web 2 right now. We think about decentralization, but we think about better safety through maybe blockchain technologies. I like to talk about this with my students and get them to think, although they're studying digital media management, so moving them from here's Web 2, here are AI tools that will help you better with your processes, your systems, understanding your customers, understanding how to approach advertising, which of these tools you should use or don't work as well. I love that we're going to see this more and more and hopefully get to that, because then that will create, I know one of the things that you think of and that you talk about around healthcare is cyber threats and infrastructure. And moving into that phase, maybe it's also very Pollyanna-ish of me because I think about the good things, but I think about how we're going to have more security and hopefully more transparency between transactions.
For sure. Well, right now, doctors' offices are reverting to fax as the best mechanism for communication because of how many phishing
Oh my
and
gosh.
cyber attacks have existed. Right. And so in general, you don't see people rise up. You see them decline to the lowest possible, lowest, safest kind of path or, mechanism. They're not a risk taker industry, but also, I mean, we saw Change Healthcare get taken down and $1 trillion payment system got taken down. And it was down for 8 months. Like for Nomi Health, it was down for 8.5 months. Some people had service restored 2 or 3 months. But Visa would have been back up in 24 hours or minutes, right? Kind of on this. And so, they kind of are reverting that, or they say, send me a paper check because I know it's secure, or, right? And that's where maybe it doesn't start with everybody, but it starts with the insurance companies or the payers themselves, as they get called them, have to pencil out. Meaning, like, there has to be, if an employer is going to be fiduciary responsible for their people, then they have to have their data. They have to be able to reconcile payments to that data, and it has to be able to be matched to whoever they rent it from. That the payment that they make to them is the same payment that goes to the provider, and can like show that it got done. It's like transaction tracing,
Yeah.
and maybe we just start there, and we do that on Medicare, and we do that on Medicaid, and we do that on commercial insurance. And all of a sudden, we're like, well, it turns out if you do it that way, then all payments should be digital because it's really hard to reconcile a paper check.
Yeah.
And it turns out if we do it that way, then, you know what I mean? Like you kind of start like, we can't think there's like a 92 things we're going to address. It's like, oh, figure out the 2 or 3 or 5 that are like the highest leverage, because once you make it so much like transformationally more efficient and you do it that way, then it turns out it's a whole lot easier to do the other 40 because they get to just piggyback onto this new innovation here, or you stop doing stupid things. That would also be a high value problem, a high value solution here.
Yeah. Can you talk a little bit about your Michigan case study? Why was Michigan a key focus, or why has it been? And
absolutely. Well, I mean, Michigan, the Midwest, to me, we've been fortunate here in Utah to have like a very, very fast growing population and economy, and it's all new. You know what I mean? Like we kind of look around, there's new buildings, new industries, new this, new that. There's very little old here. But you go to Michigan, you go to Ohio, you go to kind of the Midwest of America. I don't believe in the term Rust Belt. I think that's past. But like they've been part of like a rebirth and a reimagination around how those places work. Because that's the part of the country that builds stuff, and it's built with like it was built by the builders and the makers, right? Kind of on here, and that isn't the big auto manufacturers or these giant companies. But like you go to a place like Michigan, the number of second and third and fourth generation family businesses there are just amazing, right? And they do everything from like, we've had guys that do silicone hoses for fighter jets and this for that, you name it. And so the reason why we like Michigan is, one, it represents the workforce that we love supporting, right? A huge majority of the workforce makes less than $120,000 a year. At that point as well, you have, a workforce that's generally healthcare poor. I mean, Michigan, unfortunately, has up the fifth or top 10 highest healthcare costs. They all try to manipulate their stats for kind of different things. It's a wildly uncompetitive market. You have 2 insurance companies that kind of control the whole thing, one of which owns a health system, and their costs go up just every year. Blue Cross Blue Shield in Michigan just announced like a 13% rate increase for 2026, and it's May, and they're like, costs are going up. And you're like, why don't you do something about the costs over the next 6 months? So we like that market. There's employers that want to partner with us, providers that want to partner with us to say, let's go build something new. So what we've done there is we built our first full replacement network with a simplified model for any employer to tap into. And these employers are not the biggest companies in the country. They are the school districts, the unions, the local employers, the multi-generation family businesses, retail, hospitality, hotels, things like this. And we said, listen, there is a better way, because right now you have high deductible health plans that no one can afford. Right. And people are putting off the care until it's emergent, gets much worse, and you kind of have all these weird behavioral cues. So what we're going to try is something different. Employers are going to pay providers directly. They're going to pay first dollar, and we're going to have no copays and no deductibles, but ask for in return the real price of healthcare. And, and as a result, like we're going to come together, we're going to make it data driven and transparent, and we're going to try something different. And it's working. We launched in January with, roughly 10,000 people, like as a case study on this to say, does this work? It's working. And, you know, for 1/1/26 will probably be 40, 50,000 plus, kind of 5xing there. And that market's now being, you know, we've had a network nationwide forever, but it's got to call it deep surgery centers, bundles, ancillary stuff, you name it. We decided to go geography by geography, being full placement networks that any employer could tap into as an alternative to the traditional big insurance companies, where they go or just rent everything from them anyways. And but we want to do it with a new model. And this new model is working. And so we've gone from, you know, 10,000 lives there, growing, you know, 4 or 5x this year to, you know, now, you know, we've been invited in building this in 6 other states with kind of the next 10,
Wow.
15 right coming right behind it. Because it takes, you know, a year or two to build this network and kind of go do this. And so people are fed up, providers are fed up, employers are fed up, people that work for them are fed up. And, you know, if the three of them can all be fed up, why don't we just come to the table and figure out kind of what works differently and doesn't. So today, what that means is that any employer in Michigan that works with us can, you know, structurally change their healthcare costs on the order of 22 to 30+%. They can have no copays, no deductibles for their people. They can figure out how they want to share that all back with their people. Doesn't make sense. Like, hey, maybe it's the employer keeps some, people get most, you know, and like premium contributions a little different, or you know, like kind of how the math all pencils out. The employers that we launched with have decided to give all of it back to the people that work for them because they're like, listen, in an environment where our costs are going up 12, 13% a year, if we can keep like our employer portion flat or down 5%, but we can save our workers, you know, a $4,000 deductible, right? You know, or whatever it might be. So that like we'll be the employer of choice. We'll keep people that work for us for life. You know what I mean? Like we will have the best workforce. Like that's a good trade. And so the way we look at it is, you know, take the and employer employee portion down, you know, that 30%, and then figure out where that savings goes back to, right? And you know, the first step has been let's get rid of the deductibles, and let's you know kind of go down this path. And it's been really fun to watch.
What were the first reactions that you got when you shared this model and this new way of thinking? How are you able to brand the organization so that people understood what you're doing and didn't go, that sounds too be good to be true?
They don't believe you. Yeah, you just have to go
Okay.
prove it. Yeah, literally, you just have to go prove it, right? And you know, it's like no, like this is going to work this way, right? I mean, in most providers, most employers don't even know their data, right? So then we just say, let's ground it all in fact and truth. Let's show that what a dollar is to everybody. Oh, it turns out this dollar is $1.20 to the employer and it's 60 cents to the provider. Okay, that is waste. Right? So instead, how about provider gets paid 75 right now and the employer buys it for 80? So the employer's cost goes down and the provider's revenue goes up, and we just kind of run it this way. And you know, it takes you know it takes a few meetings to get there. And but now that we've put our points on the board, it seems to be going faster.
Yeah, fantastic. And you have case studies you can show all these other states. They're now coming in. I always feel fortunate because even as a part-time professor, as an adjunct, I have insurance through USC, which is great insurance, right?
Sure.
But with other organizations that I work for outside who've offered me insurance, I can look at that and go, no,
Yeah.
because it's not nearly as beneficial to the employee. But as you said, the more that there can be transparency between employer and employee, and the more that the employee can benefit because they're not necessarily going to raise wages or do other things, it makes us more loyal.
For sure. But also it's like it's bringing reality to the situation, right? So like if you're a school district and you're like, hey, we're paying teachers $60,000 a year. And as a result, we have a 10, 15%, you know, 15% turnover rate, and we have X percentage of positions unfilled and whatever. They generally know if they were able to pay $75,000 a year, that turnover rate would probably be cut in half. Okay. They would have like kind of like you know, we all know this. The problem is if that teacher that makes $60,000 a year has 3 kids, in most states, that costs between $35,000 and $40,000 per year just for their health care. Okay. So from a state standpoint, this is a perfect example of like a dollar is not a dollar. Okay. We talk about, oh, weighted people unit, and this is how much we spend on education, and this is how much we spend on this. Then they say, and this is how much the governor does a budget bill and says this is how much we're investing in teachers to give them raises, to do this, to do that. Okay. Well, if that school district got an extra $4,000 to give to teachers, yet a local plan says, oh, we have your benefit plan, costs are going up 12% or 10%, which is not unheard of,
Yeah.
and is very standard because they're publishing those rate increases year over year, kind of go do it. Now that if that was $35,000 a year, well, the next year now that's $39,000 a year. So that $4,000 that we as taxpayers just put into that school district to give teachers raises just got sucked up by benefits costs, which is still in the bucket of compensation for workers. But the teachers didn't feel it. They're still making $60,000 a year.
Yeah.
Who knows? Maybe they made 61. But what the effect is for our community is that we still have a 15-20% turnover rate. We're not paying competitive wages for what we need to be able to kind of go and do. And it's just going off to healthcare costs, which are just absurd, and kind of disappearing. So instead, if we could take that $34,000 and make it 27, what I mean, on here through direct purchasing and kind of getting providers out of the collections business and doing these different things. Yeah. What if we're able to then pay those teachers $70,000 a year instead of 60? Would that have a meaningful effect on retention and burnout and, being able to have our ability to hire? And I'd take that bet. I bet you it does.
Yeah.
And so that's like that's the trades, right? Because it's not just about wages for somebody. The total cost of compensation for a worker is their wage, is the benefits cost, is payroll taxes, is all these kind of other things that come together. And when you're making less than $100,000 a year but have health benefits, you're not talking about a 10 or 15% overhead rate that goes to medical. You might be talking about a 50 to 70% burden rate on somebody that makes $60,000 a year and gets health benefits from their family for in the eyes of that employer. So, again, we have to make sure a dollar is a dollar to everybody. Doesn't make sense? And kind of piece it all out, because if we could cut that cost, we could do it and we could reinvest in much better things.
Yeah. Well, and this is one of your ideas, again, is the idea of being patriotic and that solving this issue. And I think that takes us back to the beginning where you're talking about the healthcare system being the third largest economy. So can you expand on that topic a little bit more?
Yeah, I mean, so you think about U.S. healthcare as a $5.5 trillion market every year, right? That's as published, and Kaiser Family Foundation does an amazing job and just basically says it's going to keep going up, right? Here's what it is. If you look at the GDP of countries, that fits on number 3. Yeah. So it goes the U.S., China, then if it was its own country, U.S. healthcare, then Germany and the U.K. and this and that.
Crazy.
And that's just what we do. And if you think about healthcare, it's a disposable good. Because it's not like, oh, we spent $5.5 trillion this year, we won't have to spend $5.5 trillion next. It's like, no, it's $5.5 trillion, and next year will be 5.7 or 5.8. And we have to do something. And if we can just figure out how to take 20% out of this cost, just 20%, not 50, not 40, just 20%. We're talking $1 trillion of savings that would affect every employer, city, county, state, and family in America. $1 trillion back in our best. It'd be the greatest economic unlock ever. We could pave every road twice. Right? So that's where, from a sense of patriotism, a sense of what can you do for yourself, for your country? How do you measure your life? How do you do all these different things? For us, there's an opportunity to totally transform the cost of healthcare for people that work hard every single day to provide for themselves and their families. And we want to do that. And there's this macro unlock that if we are right, we will be really right, because I think we can be in a better country that's better off with that $1 trillion reinvested into better things.
Amazing.
So, yeah, let's just think, so it's not even about and what you'll find, and I'm sure you've seen this with your students over the years. Sometimes you have to connect back dollars to percents. Sometimes, so when you're small, like a 1% problem if it's sub $10 million, or $1 million, a 1% problem is $10,000. And people are like, it's not worth a paycheck to go. Then all of a sudden you have $10 million, and you're like, well, 1% is worth $100,000. And they're like, that might be worth a paycheck to go solve, right? Well, if it's 100 million and a billion, and whatever it is, but you could disconnect dollars from percents, because they, think it's a 1% problem, and they're like, it's only a 1% problem. And then all of a sudden at $100 million, you're like, that's $1 million. I think we should go solve that. I agree. We should go solve this. And, people go, I could see 20% waste in healthcare, right? I can see this, I can do this. If I just pay my doctor, they give me 25% off. We're like, well, why don't we do it for all healthcare? They're like, oh, that's a good idea. And they're like, yeah, so what would that mean? You're like, $1 trillion. You're like, what?
Yeah, that's
You're like, yeah, if we did that for every transaction of US healthcare, we would save $1 trillion a year.
that's just, I mean, that number is unimaginable.
That's the problem, right? People are like, and it's like, you could ask any like congressman, senator, governor, what president, and be like, what would you do with $1 trillion? And they're like, you could bring it down to a state in California. Like
Yeah.
California is what, 15% of the US population. What would you do with $150 billion just extra a year?
Yeah. Amazing.
So, I think it's a worthy cause. I think more people should be involved in it. I think it's some of the best work you can do. And, it's a lot of fun going and figuring out.
So, Mark, what is next for you and for Nomi?
What's next for Nomi is how to continue to drive our direct model in more states, more places. So analytics is nationwide, money movement's nationwide, pharmacy is nationwide. We have to go build networks locally, right? Whether it's Utah, California, kind of, we think of the Sun Belt, Midwest, Rockies as kind of our starting point going on. And if any provider wants to partner on a new model or do something different, like come join us. Mark at nomihealth.com. Just reach out. And we'll go do this. We want to be nationwide. We also believe there's this opportunity to take kind of data and payments innovation, real-time data, real-time payments, kind of all the sectors of healthcare over time. So we're trying to do our part to say, hey, here's what works really well in the commercial space. Maybe you should look at this on Medicare or Medicaid or other places, how we do this. But ultimately, we believe data and payments are at the core, like the utility that we can create for anyone to tap into to transform the cost of healthcare. And we're going to bring it to more places, more people, more places, more providers, more employers, and just keep going.
Yeah, fantastic. I'm really excited about your vision. I loved the fact that you shared how you and your founders came together to bring your expertise to a solution that we really need right now, that we've needed for a long time. But, I look forward to seeing how you continue to fix this broken system in the United States and then what comes after that. So thank you for bringing that into the world.
It may not be perfect. It may not always be on time, but we'll fight like hell for it. How about that?
So, Mark, I want to ask you one last question. Do you have a favorite last word of advice, mantra, motto, poem, quote, verse, words that continue to inspire you to,
to survive through it all? Just go do something. Don't talk about doing something. Just go do it. Like, what's the worst that can happen? Doing something. It doesn't work. Boo-hoo. But it might work. But it's so much better than just talking about doing something, right? And, whether it's, old Teddy Roosevelt talking about the man in the arena and kind of like, it's like the person that just kind of goes and does something rather than just criticize or talk about it, or you name it. It's like, just go try. So if you're a student, if you're this, like, because so many times you hear either no, or that won't work, or, oh, maybe we should, or talk about, whatever kind of hurdle gets put into it isn't because someone has like asymmetric expertise about why something won't work. It's just because they're fearful or they don't know, or, whatever it is. When we started Higher View, people were like, this video will never help people hire better teams, or, oh, they'll never do this or they'll never do that. And we're like, well, no, it turns out structured interviews and job simulations are the best way to hire people. Teams are more diverse, more inclusive, stay longer, perform better. And it was like, just because you end up being fearful of it doesn't mean that was not right. Yeah. Right. We just had to go try. And if someone says no, go find someone else who says yes. And so, yeah, for anyone out there, it's like, just go try. And, that's, the thing for me. It's like, hey, if something comes up, why don't we just go try it? Let's go see. Because when you stop trying as an organization or as a team or as a person, and you just worry or you're concerned about, or you don't just kind of go do it, that's hell. That's inertia. That's, you name it. And so yeah, just go try it.
Fantastic. Best advice that you could give.
Thanks. It's been helpful. Put it that way. It's like, well, we're just gonna try it because 90% of people won't try it. So let's go try it.
Yeah, amazing. Well, thank you so much for your time. I know you're off to the airport after this, so I appreciate you squeezing me in for this interview. And thank you to everybody who's watching this episode or listening to it on your favorite platform. I'll be back again with another amazing guest to share their story, their journey, some insights for you to take into your life or into your business very soon. Thanks for listening or watching to this episode of Your Brand Amplified. Don't forget to leave us a rating or review on your favorite podcast listening platform. And if you want to learn more, check us out at yourbrandamplified.com.